And staying in between the treatment of children and permanent teeth. Mark, what about the treatment of the first permanent molar? Because we know that it's often the first tooth that requires endodontic treatment in the permanent dentition. So, what are the challenges in this case, and how to deliver the optimum treatment?
The biggest challenge for me in these cases is the diagnosis, actually, because it's very difficult to have a reliable diagnosis on these teeth. The thermal tests are very difficult on children, and even when they want to explain, if they are very young children, when they want to explain the symptoms, we don't always we are not always sure that are talking about an irreversible pulpitis symptoms or reversible pulpitis. So this is a very difficult part. Of course, we want always to be more conservative when we are talking about children. So, but in some cases, when we have necrotic teeth, or we have an irreversible pulpitis, hemorrhage, then we have to do a full root canal treatment. Now, for the full root canal treatments, even the treatment, there is big challenges. The first challenge that we face, I think, I don't know if Ahmed will agree with me. I know that he does lots of treatments on children also. The first is the bleeding. We always have
Yes.
more bleeding when we are working on children. So the canals are very easy. Why? Because they are very large. But we have the bleeding problem. Before the bleeding, also, the anesthesia is very important. We have to do a very good anesthesia, especially on mandibular molars. Sometimes it's difficult to achieve also. And also the third challenge is because the canals are so easy and so large, is of course the obturation. Because it's very difficult for us to have what we love the more in endodontics obturation, which is the apical control. The apical control on children is extremely difficult.
Yes.
When the canal is very large, it's easy because we will go for maybe an apical plug. When the canal is not large, it's also easy because we can do apical control. What I don't like too much is the middle part, where the canal is not too large to do the apical part and not too small to do normal vertical compaction. So in these cases, I will go more for a technique of bioceramic sealer with a single cone technique to have more control in the apical part.
I agree with you. The problem of the bleeding is a time-consuming part of the treatment because you have to just keep activating and removing the tissues and all of this, and takes a lot of time. Um, so sometimes we have a mature root or wide apex that can be sealed with root canal treatment or an apical plug, as you just said. But sometimes at a very early stage of root development, radical treatments like pulpectomy or apical plug is not feasible when you have just more than half of the root is formed and you have a very wide apex. Sometimes we can have an option of doing a vital pulp treatment like pulpotomy. So, can you just summarize a little bit how you do the pulpotomy in immature permanent first molar, for example, in a very young patient?
Well, it's very important in these cases to, of course, to clean to isolate uh, perfectly. I mean, really perfectly, and this is something that we like to teach very well to our students. The tools before doing anything, because we don't want to have any infection coming from outside, from the decay or from anywhere. So we have to do a very good isolation, clean the decay all around, far from the pulp, and then leave the apical part of the pulpal part at the end, the exposure part at the end. Once I have the exposure, usually I don't. It's a clinical preference. I don't like to do direct pipe capping. For me, it's better to do a pulpotomy, a partial pulpotomy or a full pulpotomy, to make sure that we are not leaving any infected tissue there. And the most important sign for us till now, and I think it's a big limitation, we have to work on this, but till now, the most important sign is a subjective sign. It's the bleeding sign. So we look at the bleeding, we look at the color of the blood, and we decide if we want to do a pulpotomy or full pulpectomy. If we can stop the bleeding after few minutes just by doing a compression without using any chemical, then I will go definitely, of course, for a pulpotomy, not for a pulpectomy. And in most of the cases, I don't know for you guys, I'm not using MTA. I'm just using a putty material because it's much quicker. And as you saw on this video, I use the map system, the vital pulp therapy map system, the big one. It's very easy to do. You don't have to mix the material. You just place it in the map and just do the injection like we used to do amalgam years ago, and then compression of the material. And of course, very also important to finish the treatment and the coronal sear at the same session, and probably also the crown at the same session.
Yeah, and this is what I wanted to ask you. So, how do you choose to restore these teeth? Is stainless steel crown your go to solution? Or maybe you prefer custom made PMMAs or zirconia crown, or you select based on the patient?
Yeah, I think the choice of restoration really depends on the patient. Uh, in uncooperative, like more or less uncooperative children, I would go for a stainless steel crown. Or for children with bad oral hygiene, stainless steel crown is the fastest restoration. It's the most durable restoration. It's the easiest one to make. But today, parents are less and less inclining towards stainless steel in the mouths of their children. So we have other options. We have prefabricated zirconia crowns for permanent teeth. We also have prefabricated resin crowns that are more flexible for permanent teeth. And of course, we can, if the child is uh, able, like he's like 10, 11, 12, we can just take an impression and do a custom made crown. So this really depends on the parents. But what is very important is the part underneath the crown, between the material and the crown. This is also something that we have to have a dense and correct seal. This is why, for example, I either use SDR, for example, here, like this case, or the pre-mixed glass ionomer capsules that also give a very good coronal seal underneath the crown, or in the waiting of making a crown. This is also important, not to have any percolation.
I totally agree about it, and this question is very important because many times when we have some leakage, because we know that the stainless steel crown are prefabricated with different sizes, so definitely there will be a gap between the tooth structure and the crown. So we have seen here a lot of failures because of the material. Cementing the crown only is a cement and it's soluble, so the patient might come later with a failure of the treatment because of leakage. So what you highlighted about the material should be dense without any leakage is very important before just putting a crown with a cement that is soluble quickly. So thank you for this. And before we end this episode, we should end it again with a debate or maybe a decision that is difficult to be taken, like when a very young child is coming to the clinic with two permanent molars that are decayed and indicated for endodontic treatment. So imagine an upper and lower six in the same side, or the full four molars are involved endodontically. So how do we decide whether to treat those teeth or to do some sort of extraction to make use of the young age and the possibility of having the second molar tooth bud moving in the place of the first molar? This is a very important thing that we need to just make some points about it.
Yes, sometimes the most radical solution is sometimes the best solution, because sometimes we want to do our best, we want to save the teeth, but what's better for the patient is to extract them. I understand your question. And actually, what I like to do is whenever I see permanent teeth with very deep caries, I order an OPG and we check if there is the third molar germ present, depending on the age of the child. If the child is around the most ideal age to extract a first permanent molar is around age 9, usually 9, 8, 9, because we want the second molar to be able to replace the first molar. So it needs to also have a potential. So actually, what we should look for is half of the second molar roots are formed, and we have the third molar germ. If we have these conditions, and of course we need to take a ortho opinion. If we have all these criteria, then yes, sometimes it's better to extract these teeth early on. But this is not a decision I take on my own. I always check with the orthodontist for the occlusion of the child, and I always take an OPG to see if I have the third molar and the status of the second molar.
I agree with that, and this is very important about the position of the second molar and the root development, and also the presence of a third molar. And the most important, as you said, is the orthodontic opinion, because he has to see if one side is involved. Maybe he has to intentionally extract the other side to adjust the occlusion. Sometimes they give this option. So please, guys, if you are going through this option of extracting the first molars, you have to just consult intensely with the orthodontist. Thank you for that answer. It was important for me, especially.
We are taking advantage of your knowledge, guys. That's
Yes.
the whole point of this episode.
That's the point of the Endocast. We need to gain more experience.
So, thank you very much, Marc and Claire, for being with us.
Well, it was a great, great pleasure.
Thank you for having us.
Thank you for having us kindly.
You're the kindest people we know.
Exactly.
You too, you too.
And so, thank you everyone for watching us, and stay tuned for the next episode of Endocast.
Bye.
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 Bye. Thank you.